السلام عليكم جميعا ورحمة الله وبركاته. Good evening, everybody, and welcome to our webinar, virtual webinar, scientific event arranged and hosted by Surveyor Company. As you know all, this is the era of combined therapy, where it manages many conditions, cardiac, endocrinology, and diabetes condition, and they play major role in many aspects of compliance, control, positive impact on the long-term controlling, and positive impact in the vital organs. Now, we are going to have a presentation titled with cardiometabolic disease, holistic management, ACE-based triple therapy in management of hypertension, presented by our senior endocrinologist, Dr. Abtisam Baisa. Dr. Abtisam Baisa, she's adjunct professor of medicine, Imam Abdurrahman Ibn Faisal University, practicing as an adult consultant, internist, and endocrinologist in Al Mani Azizia Hospital, in addition to Al Rawda General Hospital. So without any further ado, let us welcome Dr. Abtisam Baisa.
Bismillah ar-Rahman ar-Rahim. Good evening, ladies and gentlemen. Thank you, Mr. Chairman, for the introduction, and I would like also to thank Survey for inviting me to give this talk. This is my disclosure. I have nothing to disclose. And this is the overall objective of my talk. After the introduction, we'll explore the impact of uncontrolled hypertension, the updated guidelines and recommendation in regards to hypertension, efficacy of ACE inhibitors versus ARBs and triple therapy, safety data on Brindobrel and triple therapy, improving patient adherence, and our discussion will be focused around one case scenario. So it's going to be interactive, so get ready. I will need your input, and then we'll have the conclusion at the end, and we'll be focusing also on single pill combination triple therapy of Brindobrel, amlodipine, and indapamide. So let me start with the introduction and the disease landscape. And as you know, all high-risk obesity is linked to cardiometabolic risk factor that includes hypertension, diabetes, dyslipidemia, and more recently also chronic kidney disease is added to obesity. And this will translate into cardiovascular disease, heart failure, and even sudden death. And this is what we call the cardiometabolic renal disease. And also more recently, this cardiovascular kidney metabolic syndrome has been staged into 5 stages, where stage 0 is the healthy stage, where you don't have any risk factor. Stage 1 is the stage of overweight and obesity and excess dysfunction, and this is the stage of impaired glucose balance or tolerance, pre-diabetes, and also the stage of pre-hypertension that we are going to discuss later. Stage 2, when you have already established chronic kidney metabolic disorders, that includes already established hypertension, diabetes, and high risk for chronic kidney disease. Stage 3 is the risk of stage of subclinical cardiovascular disease and in kidney metabolic syndrome, and very high risk for cardiovascular and chronic kidney disease, while stage 4 is the last stage. This is the stage of complication of heart failure, cardiovascular disease, peripheral vascular disease, stroke, and so on. So our aim and target, we should always target the earliest stage of this metabolic syndrome, the stage of overweight and the high risk, and the stage of pre-diabetes and pre-hypertension, and try to control it to prevent the development to second stage. Even if we don't catch those patients at this stage, stage 1, then we should at least control people at this stage, stage of hypertension and type 2 diabetes, and try to control this metabolic disorders to prevent the complications. As you all know, the prevalence of obesity in the MENA region is very high, and Saudi Arabia is considered among the top 10 countries in the prevalence of obesity. And as you can see from this chart, almost 7 countries of the top 10 countries is among the Arab countries. And According to this, because obesity is a risk factor for diabetes, we have seen also an escalation in the risk of diabetes, and it has been estimated based on the published data that the risk almost increases by 1% or more every year. And this is also linked to the risk of hypertension and cardiovascular disease. We know that in 2025, the number of hypertension patients is projected to increase to 1.5 billion. We know that also Saudi Arabia, as we mentioned, is among the areas with prevalent hypertension. However, the awareness of the diagnosis of hypertension in Saudi Arabia is less than 50%. Only 43% are aware they have hypertension, and only 35% are controlled. And this is very, very important, and we'll discuss later on. And the prevalence of hypertension in Saudi Arabia around 23%, although I personally believe that this prevalence is underestimated. And also, we know that diabetes also and hypertension are linked, and people with diabetes, many of them, 70 to 80% of them, they may have hypertension as well. We know that hypertension is a leading cause of death, and as you can see here, it is more important cause of death as more than high blood glucose and obesity combined together. We know that hypertension damages and destroys many parts of the body, as you can see here, from the eye, the kidney, the heart, and so on. We know that atherosclerosis is a progressive disease. Initially, patients are asymptomatic, and they present with symptoms when it is already advanced. They present with cardiovascular disease, cerebral vascular disease, or peripheral artery disease, or even death. And one of the most important risk factor is hypertension, as you can see here. We know that the factor that may influence cardiovascular risk in patients with hypertension is multiple, and the more the risk factor is, the more the risk for cardiovascular disease. And those risk factors that may accompany hypertension is the age, risk of smoking, family history of cardiovascular disease, obesity, dyslipidemia, history of gestational diabetes, the muscle or the metabolic dysfunction associated fatty liver disease, and established cardiovascular or renal disease or peripheral vascular disease or heart failure, as well as albuminuria. We know that albuminuria increases the risk for cardiovascular disease. And as I told you, the more the risk factor is, the more the risk for cardiovascular disease. So one risk factor as compared to 2 or triple or 4 risk factor, you duplicate the risk for cardiovascular disease. We know the mechanism, we'll not discuss it in details for the sake of time. We know the mechanism linking hypertension to coronary artery disease is multifactorial, and that may include the endothelial dysfunction, the RAS and sympathoadrenergic overactivation, and also the increase in oxidative stress and reduce the nitrous oxide, and this will result in myocardial ischemia and infarction. Similarly, systemic hypertension is linked to kidney injury through vascular, glomerular, and tubular damages and dysfunction, and this will, at the end, results in end-stage renal disease. This is very important. This is according to the European Society of Hypertension, the updated risk stratification. I know this is a little bit complicated, but they staged hypertension into 4 stages: high, normal, grade 1, grade 2, and grade 3. And also they staged the hypertension disease. The grading, this is the above one is the grading of hypertension. And here we have the staging of hypertension to stage 1, stage 2, and stage 3. And this staging will depend on the other risk factors. And as you can see, the more the risk factors you have is the higher the risk for cardiovascular disease, especially if the patient has cardiovascular, chronic kidney disease, diabetes, or established cardiovascular disease. And also you need to be familiar with the KDIGO heart heat map for the chronic kidney disease. And they also divided it into, they categorized the albuminuria into 3 stages and the GFR into, as you can see here, into 6 stages. And as you go up in the albuminuria and the eGFR, the risk increases as well. But I want to just only emphasize on that it's not always reduced eGFR and chronic kidney disease is associated with albuminuria. You can still have a normal or moderately elevated albuminuria while the patient have the risk to progress to chronic kidney disease as well as cardiovascular disease. So we need to keep this in mind as well. The lower the eGFR, the higher is the risk. So let me now start with one of the case scenario that we will have, and we'll just discuss it now, and then we'll have the answer at the end of the discussion. I need you to share with me. I know there is no raise handing, but at least you can just quickly put your answer in the chat area, and I'll just give it a few seconds for the sake of time. So please be fast with the response. So this is Mr. Ali, and I think most of you have seen patients like this. He is 52 years old man, referred for further assessment. He had type 2 diabetes for 16 years. He is on the classical combination of sulfonylurea, glimepiride, 2 milligram. He takes 3 tablets a day, total of 6 milligram. He is on metformin, 1,000 milligram twice daily, empagliflozin, 10 milligram per day, and linagliptin, 5 milligram per day. So this patient is already on 7 tablets to control his blood glucose. He's also having hypertension. He was on ARBs, losartan, increased to 100 in order to control his blood pressure, which was not controlled. Then calcium channel blockade, amlodipine was added. So now he is on 2 more tablets for hypertension. And he also has dyslipidemia. This is a common combination of the metabolic syndrome and on atorvastatin and ezetimibe. So he has also 2 more tablets. So total now of 7, 9, 11 tablets. He is a smoker, not known to have cardiovascular disease, and he does not have any chest pain. He has a strong family history of diabetes, cardiovascular disease, and dyslipidemia. His physical examination revealed on the initial visit, his blood pressure was 165/95 with and after the modification of the treatment, as I mentioned lately, the losartan 100 and calcium channel blockade or amlodipine. His current blood pressure is 136/84. He already developed background diabetic retinopathy, marked decreased pedal pulse with absent ankle reflexes, and evidence of peripheral neuropathy. He sometimes gets confused with the many medication he takes. He's already now on 11 tablets a day. This is his lab results, latest lab results. His cholesterol is 240, LDL is 131, triglyceride 160, AST is 55, and hemoglobin A1C is 9.6, eGFR is 62, albumin creatinine ratio is 335. So as you can see, most of his reading is elevated. The triglyceride and the cholesterol, LDL, is above the recommended target. This patient is at high risk of cardiovascular disease, diabetic hypertension with complication, and his target should be, as you all know, because of his very high risk, it should be below 100 and peripherally below 70 for LDL cholesterol. He has also an elevated AST. So may I ask the audience, why do you think he has an elevated ASD? Is it because of the lipid treatment or because of any of the treatment he gets? Any responses? Dr. Saleh, do we get any response from the audience?
Up to now, we are waiting.
Okay. So I want people to get awake.
Okay. So I might share with you. Yeah, there is one answer from Dr. Abdulaziz Al-Dajawi, our colleague, saying fatty liver, one of the common causes.
Perfect. So this is very important. This is a common combination of a patient. I did not put his body weight, but he is obese. His BMI is 33. Okay. So this patient has most likely his raised liver enzymes is related to fatty liver. So it is not like contraindication for lipid treatment. You should not stop lipid treatments as some colleagues may do. Okay. So this is fatty liver, combination of metabolic syndrome. So now recently called MAFLD, okay, rather than fatty liver, which is metabolic associated fatty liver disease. And also his A1C is above target, as you all know. So we need to bring his blood sugar at target, and as well as he is already have established early nephropathy, okay? So you can grade it from the KDIGO as stage G2 because his GFR and his albumin. So what is the stage? Is G2, okay? And A3, okay, based on the albuminuria. He has albuminuria of 300, albumin creatinine ratio is 335, and his eGFR is 62. So his stage G2, A3, and that will put him into a high risk for deterioration and for cardiovascular disease, okay? So this patient, the cardiovascular risk for this patient and hypertension grade, initial visit and cardiac and current visit. So what do you think? 11 months ago when he came to you with this blood pressure of 165/95, how do you grade his hypertension with the blood pressure of 165/95? I think it's easy. You can see it from the chart that you have up. So is he high normal or grade 1 or grade 2 or grade 3? Blood pressure of 165/95.
Wow, 165.
Okay? So it's easy.
Right.
Dr. Abdulaziz, Dr. Ali Abdul Latif, anyone is around? So it's easy. You can see that.
Yeah.
Okay.
It is grade 1. And Dr. Adil saying that it is grade 1. But it seemed to be that
Okay,
grade 1 up to 150.
Okay, so what I'm just trying to give you a clue. So grade 2
Yeah.
here, systolic blood pressure 160/79. His initial blood pressure was 165. Okay, his initial blood
So
pressure
Dr.
was
Abdulaziz saying that it is grade 2 rather than 1.
Grade 2, okay. And what about the current blood pressure, 136/84? Do you consider this as normal? So what is the grade of this? It's considered as high normal, okay? High normal, okay? Agree? We'll just discuss it later on. Current visit hypertension disease stage. What is his stage now? How do you stage his hypertension? I know this is complex, so that's why it has been simplified. Is he stage 1, stage 2, or stage 3? Hypertension stage 1, stage 2, or stage 3? For the current visit of 136/84. So we said stages will depend on what? On the other risk factor. So does he have any risk factors? Do you stage him as low risk, moderate risk, high, or very high with this blood pressure high normal? No answer?
Up to now?
I think by the end it will be easier for you. Okay,
Right.
so I make it easier now. So what stage he is? Does he have no other risk factor? 1 or 2 risk factor, more than 3 risk factor? He already have chronic kidney disease, grade 3, established cardiovascular disease or chronic kidney disease, grade 4 or more. So his stage?
Moderate, according to Dr. Abdulaziz Dajoui.
Moderate to high risk. So even his blood pressure is high normal, then he's still moderate to high risk. Excellent here, Dr. Abdulaziz. طيب, cardiovascular risk stratification. Cardiovascular risk stratification. You stratify his cardiovascular risk as low, moderate, moderate to high, high, or very high. It's easy from the chart that you have now. Okay? Dr. Abdulaziz, you said stage 2, so is high risk or very high or moderate risk for cardiovascular? Okay. I will not take long.
Moderate to high.
Moderate to high. Okay. Perfect. Yeah. Okay. So now let us go to the management. What would be your appropriate statement for his initial blood pressure? If you see this patient in your clinic with the blood pressure of 165/95, so what would be the best step that you will do? You will do the stepwise approach. What we mean by a stepwise approach is you start with one drug, then add a second drug if blood pressure is not controlled. Initial combination of 2 drugs would have been appropriate for this patient. Initial combination of 2 drugs in single pill would have been appropriate for this patient. Initial combination with 3 drugs would have been appropriate. Or switch from 2 drugs to 3 drugs in single pill will be appropriate for better control of his blood pressure at this stage. So which one you think is the appropriate answer?
So waiting for the answer from the audience.
Stepwise, start with one drug, add a second drug, then add a third drug, or you start with two drugs from the beginning, or start
دكتور
with
عادل عرفة D.
initial combination with three drugs. Okay.
Yeah, Dr. Abdulaziz Dajawi, 2 or 3. He didn't make his
Start
mind.
with 2 or 3. Okay. Okay. Perfect.
Yeah.
Perfect.
And
Good.
Dr. Khaldun E. Choice E.
Switch from 2 drugs to 3 drugs. Perfect. I think all of the answers may be appropriate, but we will explore it later on because it's a bit tricky case. Okay. So,
interesting.
For this patient, when he comes to you in the next visit, if you don't see him in the first visit, where he was already started on losartan 100 and amlodipine 5 milligram, and he comes to you now with a blood pressure of 136/84. So what would be your next step? He's already on losartan 100 and amlodipine 5 milligram. So what would you do with this blood pressure of 136/84? This patient blood pressure is near target, has no established cardiovascular disease, so no additional therapy is needed. Just keep the blood pressure as it is, as it would be okay for him. That's one answer. This patient is at cardiovascular high risk. He's already on ARBs and calcium channel blocker therapy, so continue on the same without any modification. Or this patient blood pressure is above target, need to add a third drug, like beta blocker or thiazide diuretic. Or this patient is a high risk, not at target blood pressure, and need treatment modification. So you may switch him to a dual therapy of ACE inhibitor plus calcium channel blocker, preferably in a single pill if it's available. Switch from those two drugs to a triple therapy of ACE inhibitor, diuretics, and calcium channel blockade in a single pill. Or need to modify treatment also to improve compliance to treatment, modify other medication to improve compliance to treatment. So which one would you select?
Any answer?
Sorry, because I cannot see your answers, the audience answers.
So Dr. Khaldun selected E. Dr.
Okay.
Abdulaziz add indapamide, and Dr. Adel selected E.
Indapamide? What is indapamide? Which answer?
I don't know. Maybe.
Which one, Dr. Abdulaziz? You have selected A, B, C, D, E, F. Which one? You mean you add either beta blocker or thiazide diuretic? Indapamide is not in the list here. I know it is true, but it's not in the list.
Yeah, I believe that he means that you add diuretic.
A diuretic, but non-thiazide diuretic. And I understand you have a point of doing that, and we will discuss it later on. Thank you, Dr. Abdulaziz.
I see.
Blood pressure of 136/84 to 140/90 is considered normal or acceptable. How many of you say yes? How many of you say no? Would you consider this as an acceptable blood pressure? Of 130 to 140, 136 to 140. Yes or no? Is it acceptable? Yes? How many of you
There is
say
2 voted with no.
And no one voted for yes?
3 no.
Okay, so none have voted for yes. Thank you very much. So this is the whole idea of the thing. Okay. So what is the blood pressure therapeutic threshold for initiating or titrating hypertension medication in your current practice? When do you start treatment? If you have a blood pressure of more than 130/80, equal to or more than 140/90, 150/95, 160/100, or continue if the patient comes with any blood pressure, you continue monitoring for 3 to 6 months and then start treatment if the blood pressure is persistently above 140/90. So which one triggers you to initiate treatment?
There is voting for A. B.
Okay. Okay. None for C, D, at least none for E. Perfect.
No, not at all. Yes.
Very good. Okay. So let me now we'll discuss the cases at the end. I'll just first give you some important briefing about the hypertension phenotypes and diagnosis. More recently, there is clustering analysis revealed distinct hypertension phenotype, okay? So you maybe have seen in your clinic that not all hypertension people are the same. Some people, they may be managed with one drug. Some they may need 2, 3 drugs. Some of them are resistance. And some of them, they have like mainly volume overload, so they will not be controlled without a diuretic. Some may have peripheral resistance, high cardiac output, RAS excess, arterial stiffness, metabolic syndrome, apart from the white coat syndrome, okay? You know all, I think the white coat syndrome is patient come to your clinic, and because of the white coat fear, they will get hypertension. Otherwise, when they monitor, their blood pressure is normal. So it's very important to differentiate those phenotypes in order to select the appropriate treatment. So optimum care in hypertension, one size does not fit all. And as I mentioned, people with salt and volume retention, they will require diuretics. People with sympathetic nervous hyperactivity, they will require beta blocker. People with arterial stiffness and vasoconstriction and peripheral resistance, calcium channel blockade would be ideal. People with RAS excess, they will need RAS blockade with ACE inhibitor or ARBs. And people with resistant hypertension, like primary hyperaldosteronism, they will need mineralocorticoid receptor antagonists like spironolactone. Most people with hypertension, they may have some element of atrial stiffness as well as RAS system effect activation. So that's why you will see most of the recommendation will focus on the RAS blockade and calcium channel blockade. Exploring the impact of uncontrolled hypertension, as we all know that every increase in blood pressure and every increment of systolic of 20 and diastolic 10 above normal, you will get doubling of the risk of vascular disease, okay, and death as well. So the higher is the blood pressure, is the higher the risk for death and vascular disease. So this underscores the critical importance of managing blood pressure to reduce cardiovascular mortality. And unfortunately, okay, about 2 in 3 treated hypertension patients have uncontrolled blood pressure. The overall estimated rate of blood pressure control in people with hypertension is 32%. And in Saudi Arabia is also similarly, as I have showed you before. And also we know that 6 in 10 people with hypertension treated by 2 drugs, they still are not controlled. So 60% uncontrolled, okay, 2 drugs, and 60 uncontrolled, and at least 30% may require more than 2 drugs, like 3 or 4. So this summarizes what I want to say. People with hypertension, at least 30% of them will be controlled with 1 drug. 40% of them, they will be controlled with 2 drugs, while the remaining 30% will require 3 or more drugs to control their blood pressure, okay? And we know problem with drug adherence. We have a lot of patients having problem to adhere to the treatment, especially if you give more tablets and more disease and to control diabetes, hypertension, hyperlipidemia. And it has been shown in studies that the more frequent you give the tablets and the more drugs you give is the less adherent the patient to treatment. And we know that people with hypertension, they have also diabetes, hyperlipidemia, they may take cardiovascular disease, and that also, the more you give the drugs, the less is the patient adherent to treatment. So we have to keep this in consideration when we treat people with hypertension, especially in elderly population where they sometimes get confused. So what about the guidelines recommendation for hypertension management? They emphasize the recent recommendation of the European Society of Hypertension, emphasize on the phenotype, as I mentioned, hypertension phenotype. So the first step is you need to confirm the diagnosis. We don't rely on one reading in the clinic because this could be white coat hypertension or could be any other thing. But we should not leave it like for 3 to 6 months as one of the options that I have mentioned in the case scenario. So you should at least do it in the clinic. You ask the patient to monitor blood pressure at home, or you use the ambulatory blood pressure monitoring, okay? So I think blood pressure devices should be given to patients with hypertension, similar to the glucometer we give to people with diabetes. They should monitor their blood pressure at home as well. The next step, you should assess for cardiovascular, other risk factor, cardiovascular, renal, or so on, because the management also will depend on those cardiovascular risk factor, and then you plan your treatment with lifestyle intervention and medication. This is the Ministry of Health hypertension definition. According to the Ministry of Health, they considered a normal blood pressure of 120/80 or less, and pre-hypertension. This is a stage 1 of metabolic syndrome of blood pressure of 120 to 139 systolic and 80 to 89 diastolic. Hypertension, anything above 140/90. And as you can see, over the past few years, you can see how the blood pressure therapeutic threshold and diagnostic threshold had came down according to as years passes. And you can see before we used to diagnose hypertension and start treatment with a blood pressure of 140/90. Now we are coming down to 130/80 and considering a target blood pressure of 120/70 to 125/75. So recent guideline uses 130/80 or less as the therapeutic threshold to achieve in management of hypertension. And this is the European Society of Cardiology again, definition of hypertension. They divided it into office blood pressure and home monitoring, ambulatory and home blood pressure monitoring. And they considered elevated blood pressure, again, anything between 120 to 139 systolic and diastolic 70 to 89 in your office. And again, the decision for treatment will depend if the patient have established cardiovascular disease or chronic kidney disease. And this is what we have discussed earlier, European Society of Hypertension, in regard to the staging. Even if the blood pressure is almost 130/85 and the patient have already established chronic kidney disease or diabetes, that will put him into moderate to high risk. And if he is already having established cardiovascular disease, that will put him into very high risk. The European Society of Cardiology have simplified the definition and recommendation to normal blood pressure, anything below 120/70, elevated blood pressure, anything above 120/70, and hypertension, anything equal to or more than 140/90. And they considered the threshold for treatment according to the European Society of Cardiology and Society of Hypertension in older adult men, elderly population. The definition of hypertension is 140/90 if they don't have cardiovascular risk, and 130 to 139 to 80/89 in people with high cardiovascular risk. This should trigger you to start treatment. Similarly, the European Society of Hypertension considered 140/90 as a therapeutic threshold for starting treatment in people aged 80 or less. While if they are older than this, then we may go a little bit more flexible with the blood pressure initiation and target treatment. And in general, blood pressure target should be less than 130/80 in people less than 65 years of age, and slightly higher in people aged 65 to 79, and you may go even more higher with the blood pressure of 150/80 for people aged 80 years or more, or those who are frail. So what is the best approach? Do we do the stepwise management versus early combination, or sequential monotherapy? What is sequential monotherapy? Sequential monotherapy is you start with one drug, okay, and then switch the patient from one drug to another drug if this drug failed to control the blood pressure. So this is not appropriate, and this is the choice B in this patient, switching from beta blocker to another class of drug like ACE inhibitor or ARBs, because 30% of patients using this approach will not respond to monotherapy, and they will continue to have high blood pressure. Stepwise approach is you start with one drug, then add second drug, and then add third or fourth or fifth in order to control the blood pressure. And this is the choice A in our patient, and this is not appropriate again, because starting with one drug, okay, still we'll see that 40% of the patient may require two drugs to control the blood pressure, and remaining 30 may not be even controlled with 3 drugs. So we'll discuss this according to the latest recommendation in the subsequent slides. Combination treatment as the first step, and I think some of you have chosen this choice, is you start with 2 drugs, especially if your recommended target decline of blood pressure is more than or equal to 20/10. Okay? And in the absence of marked elevation of blood pressure and no cardiovascular risk, you may start with one drug. Then it's preferably to start with two drugs in single pill combination, okay? Because that will improve the adherence and also provide better control of blood pressure if it is available. I know some sectors you don't have it, and then you move from 2 drugs to 3 drugs if the patient blood pressure is not controlled. And studies have shown that if you do the external combination, like you add 1 or 2 or 3 drugs, compared to the fixed combination, single pill combination, risk of discontinuation is higher with external combination than fixed ratio combination. And also, the blood pressure control is slightly better with the fixed ratio combination as compared to the free combination. So we should move now from the stepwise to the early combination with preferably if we have the single pill combination or initial use of 2 drugs. And this is what has been recommended by the European Society of Hypertension. They recommended that you should always start people with hypertension with 2 drugs that should contain either ACE inhibitor or ARBs plus calcium channel blockade or diuretics as step 1 from the beginning. And then if they are not controlled, step 2, you add the 3rd drug, whether calcium channel or diuretics if they are not already on it. Majority of the patient will be controlled with 3 drugs. And if they are still not controlled, they have resistant hypertension, you may add a 4th drug, and that could be a spironolactone, aldactone, or beta blockade. And also the recommendation is for, the preference is for single pill combination therapy to improve adherence to medication. And beta blocker should be added at any stage, especially in those with sympathetic overactivity. This is the European Society of Cardiology. It's not different than what we have mentioned earlier. They recommended, again, the low dose early combination therapy rather than starting with 1 drug, increasing the dose, adding 2nd drug. So what they recommended is initial monotherapy is limited for people with not very high blood pressure, those with no significant risk factors, and those who are frail and elderly. So monotherapy nowadays for the treatment of hypertension is limited. So the recommendation is usually to start with low dose combination therapy of 2 drugs, ACE inhibitor or ARBs, plus calcium channel blockers or diuretics. And instead of titrating the dose, if the blood pressure is not controlled, it is recommended to add a 3rd drug to control the blood pressure. If the blood pressure is still not controlled, then you can up titrate or maximize those drugs to whatever is tolerated. And if they are still resistant, then you can add more drugs like beta blocker or spironolactone. And again, they advocated the use of single pill combination therapy. So this is a slide showing you the effect of 1, 2, or 3 drugs combination in the outcome from 354 clinical trial. And as you can see here, early combination with low dose, 3 drugs is better than 2 drugs and better than a single drug in controlling the systolic and diastolic blood pressure. Not only that, but it has been proven also to reduce the risk of ischemic heart disease and stroke with 3 drugs as compared to 2 or 1 drug. So combination of 2 or 3 drugs at low dose are therefore preferable to 1 or 2 drugs at a standard or maximal dose. And this is also another trial showed that if you add a 2nd drug from another class, okay, compared to doubling the dose, they found that adding a 2nd drug from another class compared to doubling the dose resulted in 5 more effective blood pressure reduction. So adding a 2nd drug better than doubling the dose. That will result in better blood pressure control and lower side effect. So according to this, you can see all European Society of Hypertension, Cardiology, International Society of Hypertension, they all emphasized on the earlier combination therapy, whether it's dual or triple therapy, and they all emphasize and prefer single pill combination therapy, and all they emphasized on the use of ACE inhibitor, ARBs, plus calcium channel blockade, plus minus diuretics. So triple therapy is the gold standard nowadays for hypertension control, early initiation, powerful combination, and single pill combination for better results and adherence. So what about the efficacy of ACE inhibitor versus ARBs? There is one question also coming to you now. So get ready. Which RAS blockade, ACE inhibitor or ARBs? Are ACE inhibitors similar to ARBs in efficacy and cardiovascular protection? Yes or no? So can you please answer? Any answers, Dr. Saleh? Are they similar, ACE inhibitor and ARBs, in terms of cardiovascular protection?
There is yes answer.
They are similar? Okay. So ACE inhibitor is similar to ARBs?
There is 2 yes answer up to
now.
now.
No answers.
Yeah.
So I apologize. This is a wrong answer. Okay. Which class of drug has proven superior cardiovascular protection? So if you answer the above question, they are similar, then you cannot choose here. So the answer is no, they are not similar in terms of cardiovascular protection. Studies have shown that ACE inhibitor provide more cardiovascular protection as compared to ARBs. So what is the evidence? Let us discuss the evidence. As we know, ACE inhibitor block the angiotensin 1 conversion to angiotensin 2. So they will inhibit also all receptors responsible for vasoconstriction and pro-inflammatory effect. And this will result in also the increase in the bradykinin, and that will improve the hypoxia-induced new vascularization and results in corrective process to overcome the long-term effect of ischemia. While the ARBs result in selective blockade only of the receptor responsible for vasoconstriction. So that will result in slightly increasing the pro-inflammatory effect, which also results in long-term, does not overcome the long-term effect of ischemia. And the long-term of ARB therapy have been shown to play a role in microvascular ratification, cardiac remodeling, including left ventricular hypertrophy and fibrosis. So, and this is also the evidence from other study comparing ACE inhibitor versus ARBs. As you can see here, the risk of MI reduction with ACE inhibitor is 14%. In addition, you get stroke, cardiovascular death, and global death reduction, while ARBs will result in slightly significant reduction of stroke. However, some studies have shown that the myocardial infarction risk have actually increased. So there is difference in the risk of cardiovascular disease. So ARBs have many of the same clinical benefit as ACE inhibitor, including effective blood pressure lowering, improving heart failure symptoms, and inhibition of diabetic ketoacidosis. Both have the similar effect, reduction of stroke. However, the prevention and likely the prevention of new onset of diabetes and atrial fibrillation. However, ACE inhibitor produces marked and consistent reduction in MI and cardiovascular death. And this is also shown here in regards to the evidence of mortality reduction with ACE inhibitor as compared to ARBs. It's in favor of ACE inhibitor, why it's neutral in the ARBs. So let us discuss now the Brindobrel ACE inhibitor. It has been also widely studied in different scenarios of patients in regards to the morbidity and mortality. And you can see significant reduction of cardiovascular morbidity and mortality in various scenarios, people with cardiovascular disease, elderly, type 2, hypertension, heart failure, and so on. And the total risk reduction is around 14 to 28% reduction. Brindobrel, as compared to other ACE inhibitors and ARBs from other studies. First of all, as you can see here, ACE inhibitor has better reduction of mortality. And the studies looked at Brindobrel trial have shown, again, significant reduction as compared to other ACE inhibitor comparator. Again, here in the same study, looking at Brindobrel, cardiovascular mortality reduction, 22% reduction, as compared only to 12% in all other ACE inhibitor trials. So Brindobrel is superior as compared to other ACE inhibitors. And again, This is most of the guidelines recommend either ACE inhibitor or ARBs for the management of hypertension. So now let us move to the efficacy of triple therapy, brindobel, indebamide, and amlodipine. As you can see here, people started with dual therapy, ACE inhibitors with amlodipine or hydrochlorothiazide as compared to ARBs plus amlodipine or hydrochlorothiazides. If the third drug was added, triple therapy, have resulted in significant reduction of their blood pressure, whether systolic or diastolic, in 4 months for both groups, even the ACA inhibitors and ARBs. And also this effect was good in all grades of blood pressure, hypertension, and the higher the blood pressure is, the lower is reduction, and reduction can be up to 45 millimeter in systolic and 21 in diastolic. So comparing the different combination, brindobel as compared to ARBs, valsartan, and olmesartan combined with amlodipine, and indebamide, non-thiazide diuretics, and hydrochlorothiazide. As you can see, the combination of brindobel, indebamide, and amlodipine has some more sustainable effect of action over 24 hours compared to the others, where you don't get sustained effect with the other ARBs and the thiazide diuretics. And here also showing that brindobel, indebamide, calcium channel blockade resulted in significant, again, reduction of cardiovascular death and total death. So combination therapy with brindobel, indebamide, amlodipine, and this is, we call it triplexam. It's available in Saudi Arabia, resulted in achieving blood pressure control with different baseline dual therapy, achieved target blood control in different baseline blood pressure, achieved long-lasting for 24 hours control, and also protected against cardiovascular events and MACE, and superior adherence with a single pill combination of those triple drugs. So what about indebamide versus hydrochlorothiazide? So Dr. Abdulaziz was looking for indebamide among the choices, which was not there intentionally. So which one is better? So as we know here, comparing indebamide to hydrochlorothiazide, indebamide is superior as it has more sustainable efficacy. And also studies have shown it also reduces the metabolic effect and does not result in diabetes, and also has favorable effect on cardiovascular mortality, strokes, and heart failure. And also indebamide, as we mentioned, does not affect the metabolic parameters like the glucose. Rather, it has favorable effect on the cholesterol and the blood glucose as compared to thiazide diuretics. And it is commonly used and recommended in many of the guidelines and recommendations. What about the safety data? We know that one of the major concerns with RAS is the cough. However, ACE inhibitor is showing less significant cough, edema, and as you can see here, the cough induced by an ACE inhibitor is likely to decrease with concomitant use of diuretics and calcium channel blockade agent. And as you can see here, compared to ACE alone inhibitor to triple combination, the risk of cough is 0 in females. Similarly, in males as well is only 1%. So cough occurred less frequently in combination therapy with diuretics and calcium channel blockade agent, probably also due to the lower dose of the drug. Also, in regards to, we know that brindobel reduces the incidence of edema caused by calcium channel blockade, and combining brindobel with amlodipine resulted in 54% reduction in edema risk. So triple therapy have almost safe profile with reduced risk of complication. So how do we improve patient adherence with single pill combination? As we mentioned that with 1 or 2 patients on add-on therapy, they don't comply with treatments, and adherence, if you add also other drugs, the adherence to treatment become less. And as we've seen here that the using single pill combination, the time to control is even reduced rather than waiting and adding second and third drugs. So it reduced by 28%. Not only that, but also triple therapy, okay, and a single pill resulted in significant improvement to 2 drugs and to 3 drugs as add-on drugs. Okay, so 12-month adherence was highest with the single pill combination therapy. So the three pills of Brindobril, 61% of patients was adherent to treatment, while with single pill, the adherence improved to 87%. There is just quickly, I will just emphasize, I know we are running out of time. There is a more recent study called Brisigella heart study, and this study actually looked at the importance of multiple drug and low adherence, the triple therapy, and the risk of MACE and cardiovascular risk. And they included in this study people on 3 drugs, okay, or more. Group 1 is a group with Brindobril, amlodipine, and indapamide. Group 2 is other ACE inhibitors, plus calcium channel blockade and thiazide diuretics. And third group is ARBs, plus calcium channel blockade and thiazide, and the control group, other triple therapy. So, and what they found that people on the Brindobril, amlodipine, indapamide had better long-term blood pressure control as compared to all other comparators, whether it's ACE inhibitor or ARBs plus calcium channel blockade and thiazide diuretics. And also the increasing the number of antihypertensive drug to improve blood pressure control was much lower if you start with fixed combination drug with or the triple therapy with Brindobril, amlodipine, indapamide. Almost zero. You needed to add more drugs to control the blood pressure as compared to the other comparators. And also not only that, but new onset diabetes was much less as compared to the other the comparators. Left ventricular hypertrophy is less, and major cardiovascular event is also less. Fixed ratio combination, Brindobril, indapamide, amlodipine, is available in 4 flexible doses at variable doses, as you can see here, that you can choose among them. So let us go back now at the end of our talk to our patient again, how to apply the guidelines and recommendation to achieve goals and reduce risk and mortality. So as we mentioned, this patient has G2, A3 chronic kidney disease. He's also all other parameters is above target. He's already on 11 tablets. And the question, what is the cardiovascular risk for this patient? Hypertension at initial stage. And again, we understand that this patient already has multiple risk factors, peripheral vascular disease. He's already diabetic, hyperlipidemic, obese. So his cardiovascular risk, as many of you have mentioned, okay, in view also of his presence of diabetes and chronic kidney disease, he is at high risk, okay? And at current visit, even if the blood pressure went down to almost high normal, still he continued to be at high risk or moderate risk. And this patient already have 3 cardiovascular risk. The question here now is initial visit blood pressure grade 160 over 165 over 95. His grade of hypertension was grade 2, and at the latest stage now, or the latest visit, his blood pressure grade is high normal. And according to the other groups is also elevated. Current visit hypertension stage, and again, you all agree that this is stage 2 in view of the chronic kidney disease and diabetes, and he's still at moderate and high risk. So as you can see here, the whole idea of presenting this is even if you bring his blood pressure to near control and he has already other risk factors, this patient remains to be in high risk for cardiovascular disease. So you need to be aggressive in controlling his blood pressure. And also this patient, we did not say that he has cardiovascular disease, but we know people with diabetes and already established peripheral vascular disease, chronic kidney disease, they could have silent ischemic heart disease. So could this patient have cardiovascular disease asymptomatic? The answer is possible. So if already he has he has already family history of cardiovascular disease. So if he has cardiovascular disease, that will put him even at a higher cardiovascular risk, and you need to bring his blood pressure even tighter. So what would be your preferred treatment option if you see this patient at the initial visit with 165 over 95? And I think most of you have selected initial combination with 2 drug, preferably you will use fixed ratio combination, and you may switch from 2 to 3 drugs if his blood pressure is not yet controlled. And the other question with the current blood pressure management of 136 over 84. So if he's already, this patient is at high risk, not at target blood pressure. So you need to switch him to dual therapy of ACA and calcium channel blockade. He's already on calcium channel blockade and ARBs, so preferably ACE inhibitor and calcium channel blockade in single pill, and then you may add or switch to triple therapy if he is not yet controlled. And this is what the guidelines and recommendation have emphasized. And also you need to also look at the other parameters like the diabetes, the hyperlipidemia, the fatty liver, and you also need to address, and you need to preferably use a fixed ratio combination to reduce the number of tablets. If you will add a third hypertension tablet to his tablet, so you'll be taking total of 12 drugs per day. So you may reduce this 3 tablets to a single pill, so you reduce the number of tablets to 9 drugs, and you may also modify, and this is what the guidelines recommend, and you modify the other drugs for diabetes and hyperlipidemia. And also we have, fortunately, also fixed combination therapy for lipid treatment and diabetes, and you may reduce all his medication from 12 to 4 to 5 drugs per day, and that will improve his adherence definitely. So in conclusion, ladies and gentlemen, we have seen that the recent guidelines considered 120/70 as normal blood pressure. Anything above that is elevated, and hypertension is above or equal to 140. And you should always consider treatment. If the first question is if the patient does not have cardiovascular disease or at risk, then you may initiate treatment at 140/90. However, if the patient has any cardiovascular risk, then blood pressure of more than or equal to 130/80 should trigger you to start treatment. And the target blood pressure in general should be below 120/80. And when you choose between diuretics, indapamide is superior to hydrochlorothiazide, especially in people with diabetes or at risk of diabetes. And as we mentioned, ACE inhibitor is with calcium channel blockade is recommended and referred to ARBs. So take-home message, hypertension is a leading cause of cardiovascular disease, morbidity, and increased mortality. Initiate treatment with dual therapy that include ACE inhibitor and calcium channel blockade, or ARBs, but as we mentioned, ACE inhibitor is superior. Don't wait long to escalate treatment to triple blood pressure lowering drug to achieve target. The earlier is the better. And if patient age is less than 65 at high risk, then you should bring his blood pressure at least preferably to 120/70 or lower, if tolerated. And single pill combination is the best option to improve adherence and less therapeutic inertia with lower side effect and better efficacy. Fixed combination may improve adherence, as we mentioned, and monotherapy stepwise approach remain a limited option for elderly people who are frail with low cardiovascular risk. Brindobret, amlodipine, indapamide single pill combination has proven efficacy and safety profile. My own experience, I have my own experience with this single pill combination since it was in the market without any bias. It's not because I'm giving this lecture for a survey and without any conflict of interest. I had patients with resistant hypertension. They were in 3 and 4 drugs. They were not controlled with symptoms and headache. The moment I switched them to this fixed ratio combination, from within the first to the second week of initiation of treatment, their blood pressure goes down to less than 120/80 and remained controlled. So this is my own experience. Not one. I have done this in many, many, many patients, maybe more than 20 now. So I am, as you know, patients are frustrated with too many tablets, and they get confused if they are elderly. So his doctor have pulled all medication into one convenient pill, and the patient is happy with that. With that, I would like to thank you and open the floor for questions if you have any questions.
Thank you so much. As usual, Dr. Abtisam, you took us on a comprehensive, interactive, in addition to a fruitful. Really, I enjoy it. So the time is open now for a question. So pick the opportunity to ask Dr. Abtisam.
If you don't ask, I will ask.
Dr. Abdulaziz, thank you for this excellent, great presentation. Any question, Dr. Abdulaziz? All right. So, Dr. Ibtisam, I have a question actually.
Father, Doctor.
Do you have across about any evidence that the triple combination therapy improve the cardiovascular outcome compared to the dual therapy or the single therapy to start with?
I have mentioned this briefly, but I mean,
Right.
also it depends on what are the drugs that you are selecting, what combination you are using, and what monotherapy you are using. But definitely,
I
as I
see.
mentioned, the dual and triple therapy is more effective, more safe, and combining brindublet with calcium channel blockade resulted in lower cardiovascular risk and also mortality. So again, it depends on the class and it depends on the drug within the class. So the risk is different. And there are many studies looked at this, and I think I showed some of them. I'm sorry, it's too fast. But again, as I mentioned, ACE inhibitor is superior to ARBs in terms of cardiovascular and mortality and morbidity. And brindobrel, as compared to other ACE inhibitor, has also superior results. Yes. And of
That's
course,
good.
if we talk diuretics, thiazides versus indibamide, definitely indibamide have shown some cardiovascular benefit as well.
I see. All right. Since there is no other question from the audience, I'll ask another question. Is there any specific patient population to recommend as initially starting triple therapy from the beginning? I know that you have mentioned that
Yes. Yeah.
quickly, but I want to stress more about it.
Yeah, usually patient with very high blood pressure and very high cardiovascular risk, you may start with triple therapy. For example, our
Right.
patient initial blood pressure was very high to start with, and I think some of the audience have selected starting with triple therapy. It could be an appropriate option as well. People with severe
Mm.
hypertension, cardiovascular risk, yes, it's all right to start with triple therapy.
Mhm. I see. Still, there is no encouraging one to have
Either they have
a
understood
question.
everything or they are slept already.
Okay. No, I think it is too interactive and enjoyable, actually.
Thank you very
Okay.
much, Dr. Saleh.
All right.
لحظة
Uh,
دكتور لحظة, there is question coming now.
really? Okay, good. Let me go over the chat and see. Yes. Uh, Dr. Khaldun asking, patient with high risk of cardiac risk with DM, what medication to control his blood pressure
Diabetes.
and diabetes too? Yes, right.
Medication to control his blood pressure and diabetes. Okay, I mean blood pressure, as we
Tentatively.
mentioned. Again, the question is a bit wide, but I mean, and let us now focus on hypertension. Again, it depends on the level. It depends on the risk, cardiovascular risk, the kidney
Mhm.
risk as well. As we said, the more the risk, the higher the more control you need for his blood pressure. So you need, and again, as we mentioned, AC. Again, I will mention AC inhibitor plus calcium channel blockade and indibamide would be the best option for people with type 2 diabetes, because indibamide have less effect on the metabolic, the hyperlipidemia, and the diabetes. And also, at what, for how long you need to control, how much you need to bring his blood pressure. And I think if patient can tolerate blood pressure of 120 over 70 or lower, that would be perfect. And for his diabetes, again, that will need another talk. For his diabetes, again, it depends on what risk he has. If he has, now the guidelines have changed. If he has
Right.
cardiovascular disease, kidney disease, then you have to select GLP-1, SGL2 inhibitor. And if he has fatty liver, now it's already included in the recommendation. You should add GLP-1 receptor agonist, in addition
Mhm.
to other parameters based on the blood sugar elevation.
Mhm. Dr. Abdulaziz Dajawi concerned about the secondary hypertension and at which level of blood pressure you should think of secondary hypertension.
Of course. I mean, I have put it in the slide, but I did not mention about it. Secondary hypertension should be always considered in younger populations and in resistant hypertension. And the latest guidelines and recommendation, they recommend screening all people with hypertension for hyperaldosteronism. You check their aldosterone level, okay? So it is recommended to check their aldosterone before you initiate treatment. So secondary hypertension also depends on the clinical scenario, the history, if the patient have any suggested pheochromocytoma, hyperkalemia, hypokalemia. But in general, younger population, resistant hypertension, yes, definitely.
Sure. Dr. Khaldun have an interested in asking about IMBA versus DABA. I don't know whether he's asking about the related to the blood pressure or diabetes, but it seems to be he's asking about kidney protection. I don't know whether it is related.
Okay. Can you answer? Okay. I mean, this is another talk. Actually, we need another presentation.
Yeah. It is.
But both drugs can have some, if you're talking about hypertension, some of them, they have some effect on the blood pressure. And both of them have shown to be effective on chronic kidney disease without going into details. Of course, which one is better than the other, which studies have shown that this one have better at what doses, which one. So I think we need another presentation for that. But both of them are effective.
I agree totally.
Both of them are effective for kidney disease. Yeah.
I agree with you, yes. Yep, thank you from Dr. Khaldun. Right. Okay. All right. I think with that, there is no any further question from the audience. So we can conclude here, and thank you so much, Surveyor Company, for hosting and arranging such really very useful presentation and knowledgeable presentation from Dr. Ibtisam Baisa. Thank you so much, Dr. Ibtisam, for this great effort, actually, to collect all of these data, comparing all of the antihypertensive items, and come up with a clear picture how to select, how to combine, which better combination, and what is the long-term positive impact on the patient in protecting his heart and kidney. Thanks so much, and I appreciate for the audience their participation. And have a good night.
Thank you, Dr. Saleh. Thank you, Surveyor. And thank you for the audience who stayed with us till this time. Thank you very much.
Thank you. Thank you.